Alright, everybody. I'm Tatsuya Nakama from Tokyo Bay Medical Center, Japan. Today, I'd like to introduce the result of our GRIFFIN study. GRIFFIN study is evaluated the relationship between the FFR and the lift loss after the DCP angioplasty for femoral popliteal lesions. Recently, in the field of the coronary intervention, the relationship between the FFR and the indication of the revascularization, also outcome of the outcome after PCI is frequently reported. However, there is not so much about scientific data of FFR value and DCB angioplasty. So we want to make some of the scientific data about the FFR in the FFR in the peripheral artery disease and vascular treatment for peripheral artery disease. So in the field, for the stenting strategies, some of the physicians already reported the relationship between the FFR and the result of the stent angioplasty and stenting. However, recently stenting is not so mainstream strategy especially for the femoral popliteal segment, because due to the very flexibility of the femoral popliteal segment, stenting strategy is sometimes make a problem. There, leave nothing behind strategy like DCB angioplasty became mainstream, and the market share is gradually increasing. Now, so in these studies, we evaluate the result of the DCB angioplasty with the FFR value. DCB angioplasty, as you know, DCB angioplasty includes a much amount of the problem, like impossible to control the recoil, and also don't have enough ability to prevent the dissections. They don't have ability to repair the dissections because it's only a balloon-based strategy. Therefore, it sometimes fail, but there is no objective evaluation system about the angioplasty failure, DCB angioplasty failure. We mainly evaluate it using only angiography. It's a very subjective finding. For example, this form classification is frequently used, but it's very subjective and not so much scientific data about the relationship between this form classification and the result of the DCB angioplasty. We really need very objective, scientific evaluated definition about the angioplasty failure. We thought FFR value is directly evaluate the flow disturbance about the, of course, before and after the DCB, after the angioplasty. Therefore, evaluation of the FFR after the angioplasty may directly related to the result of the angioplasty itself. Therefore, we tried to start the GRIFFIN study, evaluation of the relationship between the FFR and outcome of the outcome after DCB angioplasty. The study is a prospective match study. It was held in between January to December 2023. Unfortunately, the number is not so huge. Total 126 patients were enrolled in this GRIFFIN study. The inclusion criteria is Rutherford 2 to 4, Rutherford 5 and 6. Tissue loss patient is excluded of these studies. Only de novo FP lesions were included. After the conventional angioplasty, clear angioplasty failure patient like person diameter stenosis over 50% on their own angiography, or angiographical clear severe dissection. It means type D dissection with flow delay were excluded. After the evaluations, total 103 patients were finally enrolled, and 12 months follow-up were performed. Total 103 patients. We classified into the patient between the two groups, restenosis cases and non-restenosis cases. Definition of the restenosis is defined as a PSBR over 2.4 by duplex ultrasound, or percent diameter stenosis over 50% on angiography, and decrease in AVA level of 0.2. Then we try to compare the FFR value just after the DCB angioplasty and instance of the restenosis on 12 months. As we expected, there is a significant difference between the FFR values between the restenosis patient and the non-restenosis patient. The restenosis patient showed significantly lower FFR values, 0.85, and non-restenosis cases were significantly higher FFR value, 0.96. It means higher FFR value showed non-restenosis. It's very easy to understand. And after the multivariate analysis, FFR value itself is clearly visualized as independent predictor of the restenosis. Where no restenosis predictor of the percent diameter stenosis and dissection grade is not associated to the restenosis in these studies, because super severe dissection over type D and significant residual stenosis cases over 50% were excluded. Then we tried to evaluate the cutoff value of cutoff FFR values of the restenosis after the DCB angioplasty. We describe the ROC curve using this data, and finally 0.92 is a very good cutoff value for the restenosis. It was pointed out. P-value is 0.0003. As you can see, if we classified the groups using this 0.92 FFR values, over 0.92 cases were shown only 6% restenosis. However, if the FFR value is lower than 0.92, as you can see, 33% restenosis were observed. This is a quite remarkable findings. Actually, so this is not so big, huge number of studies. Therefore, very unexpected result and amazing result are not observed. But interesting point is this 0.92 value, FFR value cutoff value, is clearly similar to the previously reported FFR cutoff value for the drug editing stent, restenosis after drug editing stent. It's quite interesting findings. It's very clear. After the DCB angioplasty, we evaluate only the result of the DCB angioplasty was evaluated only with angiography. It's quite subjective findings. It's as already reported, the evaluation of the dissection grade and residual stenosis. It means the result of the angioplasty is very decision is very heterogeneous. Many physicians have their opinions. It's very difficult to finds a clear result. However, if we use this FFR values, evaluation of the FFR after decibel angioplasty, we can clearly find that this angioplasty is failed or not. Easy expected the clinical outcomes. Therefore, use of the FFR value is significantly useful for in a daily clinical practice. Thank you very much. This is only a small number of studies, and actually, so hyperlinear technique in this study we use probably 30 milligrams for the hyperlemia, but many of the this kind of technique is not fully established in the huge trials. Therefore, the next step is more and also as a if we have value and some of the dissection grade and everything is not evaluated, is evaluated with only on-site. Therefore, more controlled, collaborative adjudicated, and also a much number of patient, with much number of patient study, maybe reasonable to evaluate this kind of reported FFR value. And if possible, a randomized control trial may be a reasonable next step to establish the actual result. For example, if angioplasty, after the angioplasty, stent-based strategy versus DCB strategy, or some kind of the randomized trial may be a reasonable step.